Good morning, everyone, and welcome to the latest episode of PYA's Healthcare Regulatory Roundup webinar series. And today's topic is 2024 Proposed Rules Part 1. PYA is happy to present today's webinar on this important topic. Now, a little bit different today. Before we get started, I want to go over some housekeeping items. As this event is for CPE credit, there are some additional steps we'll have to take in order to comply with NASBA's requests. In accordance with NASBA, attendees will be provided 3 polling questions throughout today's presentation. Responses are documented electronically. You must respond to these polling questions within the allotted time in order to receive CPE credit for this presentation. If you encounter any issues responding to the polls, please send your answer in the questions pane, and we'll document them for your CPE credit. A post-event survey will also be provided for attendees to submit regarding their webinar experience. The polling questions and post-event survey must be submitted for proof of participation today. Credits will only be earned for sessions attended in their entirety. You may also submit questions during the webinar by typing a message in the questions pane of the control panel, and immediately following the webinar, again, you'll complete that short survey and submit additional questions. We will respond to any questions you have after the webinar via email. We've posted in the handouts pane of the control panel a PDF copy of the slides for your reference. Also, you'll receive an email later today with a copy of the slides and recording of this webinar. With that, I'll hand it over to our presenters, Martie Ross and Kathy Reep.
Good morning. Boy, you never know what you're going to have. You should never, I guess it's the issue of I ask for a pony for Christmas, so I'm sure that I'm going to get it. But no, we did not get an outpatient proposed rule. Marty and Kathy are sitting here with egg on our face, but that doesn't mean we aren't going to talk about the outpatient proposed rule. As we had originally planned this webinar, we were looking at an outpatient rule that we just knew was going to come out. It actually dropped from OMB the Friday before the 4th of July weekend, if I remember correctly. So actually dropped a couple of days before that because we knew that Friday afternoon we were going to have a rule to read over the long weekend. We did not get the outpatient rule. So then we assumed it was going to come out on Monday before the 4th and that we would have something to do that Tuesday. We had continued to say to each other, I'm sure I'm going to have a rule to read tonight. It's going to be here. Even to the point of, I believe yesterday we were saying, so we'll read it real early in the morning before we do the presentation today. Well, no, Kathy and Marty are punting, we're tap dancing, we're doing all of those different things this morning and saying, you're going to get the outpatient proposed rule in a slightly different format, your input. But then we're going to talk about a different outpatient rule that was published related to 340B. We're going to talk about home health, end-stage renal disease proposed rules, requests for information related to medical payments, and then give you an update as it relates to the No Surprises Act. So we're going to get it covered. We're going to make good use of your time. We promised you CPE, and you're going to get CPE. So let's start with the issue of the outpatient rule. I mentioned that the outpatient rule was, Marty, next slide. The outpatient rule was at OMB. It has been off of the OMB website for over a week. And so we gut feel tomorrow, late this afternoon, just out of spite. But I think we will have it this week. Therefore, you will be getting another webinar on the outpatient rule that we'll talk about shortly. But with that, we're going to put you to work and we're going to give you a polling question related to the outpatient rule.
And I'm Shannon. I'll be giving you that polling question. Your question here, the market basket update in the 2024 OPS proposed rule will be sufficient to address increased hospital operating costs. Please select one, agree, disagree, or unsure. You have about 30 seconds to answer this question.
Gut feel we're going to be 100% on one of these.
All right, ladies, back to you.
Ah, all right, not quite. Okay. Those of you who said disagree, I think you're probably in the right. The inpatient rule, I think the total update was about 2.8% that they proposed. We don't have that final rule yet. There's been a lot of argument related to that 2.8 and that it wasn't enough based upon the increased costs of healthcare. The outpatient rule should be using more current information than the inpatient rule did. However, it actually has sat at OMB for several months. It was at OMB before the inpatient rule was issued, proposed rule was issued, if I remember correctly. So not sure about the data they're using. We are, aware that the inpatient rule used much older information than they will use on the final rule. But Martie, what do you foresee in terms of, are they going to get it right?
I am no longer predicting anything CMS is doing, right, after this debacle. I'm being convinced. I think Kathy and I just convinced each other the rule is going to be published, but I suspect there will be room to convince CMS that rate should be higher. How's that? So, but let's talk about the one OPPS rule we do have, Kathy.
As it relates
to OPPS rule.
Yes, OPPS. So let's go to the issue of the 340B. And I think we mentioned even on a previous webinar that there was a proposed rule sitting at the Office of Management and Budget that was on the remedy for those hospitals that were underpaid when CMS reduced the payment for 340B drugs or drugs acquired under the 340B program. This rule was published on July 11th. Comments are due September 11th, but recognize that with this, the issue is going to be, they have indicated that they want to publish this rule. Actually, Martie, I think we've got an issue there. I believe the comments are due the 5th.
Now I checked, because it actually, so there's released when it goes to public inspection, there's published when it's actually in the Federal Register, and the Federal Register from yesterday actually said the comments were due on the 11th.
Okay, interesting, because most of the summaries have addressed the 5th, so that's interesting that there's actually going to be a little bit more of a leeway. Of course, with our luck, they're going to turn around and change that and publish a correction to the comment period. That will come out on December 4th. I said September 4th. But let's go and talk a little bit of background about this 340B issue. The whole argument related to 340B has not been the way the 340B program works. It's not the appropriateness of 340B and the ability to buy drugs through a particular program, or certain hospitals being covered under 340B and other hospitals not. That is subject of some legislation that has been being discussed in Congress, and perhaps changes at that point to the 340B program. But the litigation that was involved in the American Hospital Association v. Becerra really goes back to an adjustment that CMS made in 2018 and how they did this. The Medicare Payment Advisory Commission had addressed the fact that they felt that hospitals who were 340B providers were receiving a quote unquote windfall. I don't think those providers are going to say that they were receiving a windfall, but MedPAC was concerned that they were being overpaid for 340B drugs because of the amount of the discount that you as a provider received when you purchased those drugs. Therefore, CMS came along and they said in 2018 that what we're going to do is we're going to pay for most drugs at average sales price plus 6%. But for those drugs that were acquired through the 340B program, we're going to pay average sales price minus 22.5. Where did they get the 22.5? MedPAC said that was approximately how much hospitals were being overpaid. Can you just arbitrarily make a decision and pick a number out of the blue? No, you can't. There's a requirement, and this was what the courts held, was that there is a requirement if CMS wants to modify the payment rate, they are going to have to do a survey of providers. They actually started the survey at one point, did not follow through with it, but there is this issue of, at some point, will CMS do a survey of what you're actually paying for these 340B drugs? But because they did not, they just arbitrarily reduced the price, there was litigation. Now you got to understand that it had to be, that reduction in price had to be done in a budget neutral manner. So while they reduced the price for what was paid for 340B drugs to average sales price minus 22.5, they increased the amount of money that went into the base rate, and that there was a bump in the base rate to all providers for all services that they provided. So that less than $100 figure that you're looking at as a base rate would go up. And that would apply to those hospitals that were not 340B providers and those that were. So there was this bump. Overall, we're looking at about a 3.1 or 3.2% increase in the OPPS rate during the period of this program. There was litigation filed by the American Hospital Association, obviously, as you see from the title of the slide, the AHA v. Becerra. The Supreme Court ruled in the favor of the American Hospital Association that what CMS did, not doing a survey, was inappropriate. The Supreme Court did not say this is what you need to do. They remanded it back to the district court to determine a remedy, and basically the district court then turned around and said, CMS, figure out how you're going to make hospitals whole. CMS did move forward beginning in calendar year 2023 to pay average sales price plus 6% for these drugs, and they reprocessed claims going back to 2022, back to January 1 of 2022. So the remedy that Martie is going to talk about essentially is going to go through calendar year 2018 to the period of time that the claims were not reprocessed for. So Martie, how are they going to make us whole?
Well, just one more thing on what CMS did last year. Because they went back to ASP plus 6, they reversed that across the board increase in the conversion factor.
Right.
So that's why we saw a lower conversion factor last year, is because that 3% bump that we have been living high on the hog since 2018 disappeared. Because now we had to pay, CMS says budget neutral, we have to go back to paying for these higher drugs will be a higher cost, so we're going to reduce the conversion factor. So again, this is a lot of Robin Hood going on here, right? Take from one to give to the other through all of this. But let's talk about, so CMS says, I promise, Judge, we're going to come up with a great solution to this. And this is their proposed remedy in the proposed rule. So they intend to make a one-time lump sum hospital to the approximately 1,650 340B hospitals based on the difference between what they would have received under the ASP plus 6% versus what they did receive under the ASP minus 22%. Now remember, this is only the hospitals that are reimbursed on OPPS. So even though our critical access hospitals are also 340B hospitals in many cases, they're not going to see this adjustment because they didn't see the adjustment in their payment under OPPS. But CMS estimates this amount, which includes the difference in the beneficiary copayment amount, is about $9 billion. So that's important to note, though, that because the drug price had gone down during this period of time, the copay amount for beneficiaries was lower. But CMS says we're not going to go and require you to rebill beneficiaries or rebill their Medicare supplemental plan. We're just going to create a remedy that includes that difference in the beneficiary copay amount as well. Now you see there, for those of you that enjoy algebra, the formula that CMS is utilizing to make these calculations, where Y is the total amount a hospital received under the 340B policy between January of 2018 and September of 2022. So you can do your own back of the napkin math if you have that information available to you. CMS promises that the payments will be made, that check will be in the mail or will be made electronically by the MACs within 60 days of CMS providing instructions. They expect that to occur in late 2023 or 2024, assuming that this proposal is finalized as proposed by CMS. But there's the rest of the story, right? CMS says, well, wait a second, this has to be done in a budget neutral manner. And we can't therefore allow hospitals to retain that 3% bump in the OPPS conversion factor. We have to figure out a way to call that money back since we're now paying it out through this lump sum payment. So what CMS proposes as its solution to adjust the OPPS conversion factor on a going forward basis by -0.5%, starting not next year, but in 2025, and continuing it for, wait for it, 16 years. So about the time that we get done with sequestration, it appears we will also be done with the 0.5% adjustment to OPPS to, again, claw back that money. So clearly, there are winners and losers under this proposed remedy. It's going to benefit some hospitals and not benefit others. So Shannon, that takes us to polling question number 2.
Wait, Marty, before we do
Oh, hold on. Okay, go ahead.
I have a question.
Okay.
I have a Medicare managed care contract that my contract says that I will pay you under the OPPS as Medicare would pay you. There are no, I mean, I'm going to use the same base rate. I'm going to use all the same little rules and things like that. What happens with those providers that are 340B providers? Are the plans going to give them a retro payment to make up for this? What about those who are not 340B providers? Are they going to have this recoupment? And those that are 340B, are they going to have the recoupment as well? Gut feel.
Why, Kathy, I think that's an excellent comment that could be submitted to this proposed rule, is how will this impact Medicare Advantage?
And I think the answer to that is going to be, that is between the provider and the Medicare Advantage plan, because they have a contract, we are out of it.
So maybe that impacts how this rule, applies to your organization. And appreciate, there's also going to be a lot of organizations that are 340B organizations, but have relatively low volume of otherwise payable drugs.
Right.
That they actually probably received more from the 3% bump across the board on all their outpatient services than they did from 340B. So
I would urge, for those of you who have contracts that under the OPPS you are paid as Medicare would pay, you need to start talking with them right now about how they plan to address this adjustment. I seriously don't think CMS will say, I don't think they will respond. If they do respond, they would say that's between you and the entity with whom you've contracted. So you need to start having that discussion right now. Can't finalize it until we get a final rule here. But I do know that the argument originally was that this be done with new money, and that those 1,600 plus hospitals be made whole, but they not adjust the conversion factor. CMS isn't doing it that way. They are not doing it with new money. Therefore, we are definitely in a situation of winners and losers.
correct. So to that point, Shannon, over to you.
You got it. Our next question here. Does CMS's proposed 340B remedy help or hurt your organization? Help, hurt, unsure, or my organization is not impacted? Remember, you must answer these questions in order to get CPE credit. Give you just a few more seconds. Martie, Kathy, let's see what we got.
I agree with people that say unsure at this
Agreed.
point, absolutely. But very interesting. And as part of this proposed rule, if you go back and read it, they analyze which hospitals are benefit, who's going to be the winners, who's going to be the losers. Not surprisingly, academic medical centers are at the top of the heap because obviously they're probably generating the greatest 340B revenue with the resale of those discounted drugs. But certainly it's going to be a very interesting time and one you really want to consider commenting on. One more interesting point of this is, CMS writes everything in pencil, as we've learned, that they will, and we're really going to learn that when we start talking about the home health proposed rule this year. But they have this opportunity to write a rule and then come back and make adjustments to it. And so this is the question is, well, are we going to make the lump sum payment and then, yes, you claim we're going to repay it over 16 years, but will they decide to accelerate that? And I hope the answer to that is no, because whatever remedy is that's finalized by CMS still has to be approved by the court. I mean, because this is ongoing litigation, and the district court's job is to enter a remedy. And so whatever CMS agrees to or presents as a final rule will become reduced to a court order. So hopefully that provides us some protection as opposed to any acceleration of this repayment beyond the 16 years.
But I think those of you who are 340B hospitals and are looking forward to this lump sum payment need to make sure you also comment on this rule, because I guarantee you those providers who could be harmed by this are going to be commenting on that 0.5% reduction to their base rate.
So let's move on to a nice, juicy, substantive rule with the 2024 Home Health PPS proposed rule. Now, those of you who are not home health agency providers, do not tune this out because as we go through what CMS is proposing to do to adjust the base payment rate for HHA, it is a lesson in how CMS manages budget neutrality and how they take from one to give to the other, how they perform calculations to determine changes in provider behavior and how that impacts payment. And very much so is a roadmap on how CMS would implement a new payment model. Now, granted, we know that the skilled nursing facilities and home health agencies in the last couple of years have gone through a dramatic change in their payment methodology. But there could be others on the horizon. And I think there's a lot of lessons here on how CMS has approached the HHA adjustments that are very interesting more broadly in the industry and most likely worthy of your comment going forward. So let's start at the beginning of the story, which is the change to payment-driven groupings model, or the PDGM model for HHA reimbursement. Back in 2018, in the Balanced Budget Act 2018, Congress said, CMS created a new payment model for home health agencies. Here's the rough parameters. CMS implemented that in 2020, sort of a rough start, obviously, because right thereafter, COVID. But they have implemented this model, which goes from a 60-day period that's where payment is driven primarily by what the home health agency does for the patient, to a 30-day payment period where payment is much more driven by the patient's condition. And so there's clearly, when you're changing behaviors and you start paying a provider to do something differently, Congress, in authorizing this new payment model, told CMS, be sure that you account for behavior changes, because we don't want to end up paying home health agencies more. We want to spend the same amount of money that we would have spent under the old model. We just want to buy something different with that money. And so CMS, be sure that you're appropriately reviewing the claims data, and if in fact home health agencies are adjusting their behavior to maximize reimbursement and thus increase spend, that you apply budget neutrality rules to prevent that from happening. Okay, so under this PDGM model, you start with a national standardized 30-day period payment rate. So whatever that payment rate is, it's, say, for our examples, it's $100, and everyone's going to be paid that across the nation. That's the base. There are then a series of agency-specific adjustments. So we have a wage index adjustment. We have adjustments based on performance under the quality, well, the reporting under the quality reporting program, and then performance under value-based purchasing models. So your $100, say, is now gone to 110 based on those agency-specific adjustments. Then that base rate is going to vary by the case, the individual case. So what CMS has created, and you see this in the color on that right-hand side of the screen, is this series of categorizations of an individual episode of care based on, you know, how was the patient admitted to home health? What clinical grouping do they fall in? What's their functional impairment level? And what's the comorbidity adjustment? So those secondary diagnoses. And what you end up with, applying these different considerations, is 432 separate home health resource groups. And for each home health resource group, CMS assigns a weight. And then you multiply your agency-specific adjusted standardized payment rate times that weight to that home health resource group, and voila, you end up with the payment rate. We then have some additional adjustments that are made based on low utilization or partial periods, some outlier exceptions, as well as at least for a few more days or weeks, a rural add-on payment as well. So that's how this model works. And obviously it's a significant difference in how we're going to reimburse home health agencies. So for 2024, CMS is proposing a 2.2% reduction to the base rate, meaning that it would spend $375 million less on home health services than it did in 2023. How do we get there? Well, we start with the market basket increase. So has the cost of delivering this service gone up? And CMS says, yes, the data indicates that cost has gone up, and so we intend to adjust the market basket by 2.7%. And that would have regenerated a $460 million increase in the amount we paid home health agencies. But wait, CMS made some other adjustments to market basket update, saying let's start using 21 data as opposed to the prior data that we use. Let's make a change to the labor-related share, as we always seem to do, a little adjustment there. So we may make those changes. They propose those changes. But then the big whammy is that 5.1% prospective permanent behavior assumption adjustment, which results in an $870 million decrease in the amount paid for all HHAs in 2024. Then there is also, on top of that, the final adjustment is a 0.2% increase due to the proposed update to the fixed dollar ratio. That's the formula used to calculate the outliers. That ends up being a $35 million increase. Obviously, the big story here is that behavior assumption adjustment. That is accounting for the difference between what CMS thought home health agencies would do in response to this new model and what, in fact, the claim data shows that they are doing. So yes, when they built this model, they made assumptions about how home health agencies would change behavior to maximize reimbursement. What they're saying is we underestimated how impactful those behavior assumptions, those behavior changes would be. And so what we've determined is that we're going to have to make a significant change based on HHA's behavior regarding clinical group coding, comorbidity coding, as well as the low utilization payment adjustment. And so that's why you end up with this permanent adjustment going forward. So we're recalibrating how that base rate is calculated going forward. Now, CMS did this in 2023 as well. It just way underestimated the amount. The adjustment they proposed to 2023 was about half of what now they're saying in 2024 the data shows is appropriate.
And they did it in skilled nursing as well. They did it last year in skilled nursing. They're proposing it again this year in skilled nursing. So again, it is, their assumptions were wrong, and therefore we're going to recoup.
Exactly. Even though it's a prospective payment system, we're going to go ahead and change the rules on a retrospective basis. Very short, the rule was published at the end of June, was released in the for public inspection at the end of June. On July 5th, the National Association for Home Care and Hospice filed a lawsuit challenging the behavior assumption adjustment for 2023, saying that that methodology was arbitrary and capricious, given that CMS is effectively using the same methodology now in 2024. The relief sought by the association is to also enjoin the use of that methodology for 2024. So this one, even still in its proposed rule stage, is already the subject of litigation. So Kathy, I have to ask you this because this has just been gnawing at me. The whole idea of a prospective payment system is that there's winners and losers, right? It's like we're going to use the data available to us historically. We're going to apply some actuarial assumptions, and that's the rate we're going to pay you for a period of time. And even if our assumptions were faulty on the back end, we're not going to go back and fix them. I mean, this is sort of the whole wage index issue, right? That CMS, you know you've made mistakes with the wage index. Why don't you go back and fix it and retrospectively adjust those payments made to hospitals? Now, that's very apparent to me. That's what they're doing here. They're making a retrospective adjustment to a prospective payment system. How does that work?
Because the implementing statute required the change from a 60-day episode of care to a 30-day episode of care to be done in a budget neutral manner.
So CMS says we have the authority to do this, and not only do it once, do it twice.
Budget neutrality. And so that thing was skilled nursing to maintain budget neutrality. Now, going back to the outpatient 340B issue, because CMS is being told to fix this, okay, come up with a method, there is nothing that addresses, as far as I have remember seeing, the requirement that it be budget neutral.
They're just choosing to do that as part of the remedy they're proposing first to us, which then I guess they will present to the court.
Even though American Hospital Association, others said, just fix the 340B underpayment, ignore the other side of it. CMS is moving forward with doing it in a budget neutral manner, which
interesting.
There is no requirement to do it budget neutrally. In these particular cases, skilled nursing and home health, there is.
And as I said, these rules are really insight into how CMS is going to move forward, with any type of due payment model at the adjustments they'll make. So there's more. I mean, obviously that is the frontline story for home health agencies, is that anticipated cut to reimbursement driven by, in large part, that behavioral assumption adjustment. There are other changes that they have proposed as well. Again, new payment model, they are still, kicking the wheels and making the adjustments. They intend to recalibrate the PDGM case mix weight. So remember, it's base rate, facility adjustments times the case mix weights. They're readjusting those based on the data they're seeing 3 years into this model. They're updating the low utilization payment adjustment thresholds, the functional impairment levels, and the comorbidity adjustment subgroup. So again, we've got the 432 categories. We're just trying to make sure we've got those appropriately defined. But they are also, CMS is also proposing, under the authority of the Consolidated Appropriations Act of 2023, to establish separate payment outside of the base rate and case adjustment, but a separate payment for disposable devices that are used in negative pressure wound therapy. So there's new revenue available under that proposal, which of course was directed by Congress to provide that additional reimbursement. And finally, CMS is establishing regulations to implement payments for items and services under 2 new benefits, words I cannot pronounce, but you can read here on the screen. So again, that's new monies being finally read into the regulations with these new benefits. So that's coming also. Other changes in the HH rule concern the home health quality reporting program. And just like other quality reporting programs, the obligation of the agency here is to report the data to avoid a negative adjustment to their market basket adjustment. But here they're proposing 2 new measures, a more streamlined COVID-19 vaccination measure, as well as a more streamlined functional discharge score. And again, this is driven by this transition to this new payment model, meaning there's new data being collected and reported. And so that allows utilization of a more refined measure to evaluate HHA performance. Similarly, the 3 measures they propose to remove from the quality reporting program are also ones where there is better data now available, or in the case of the OASIS measures, they're no longer necessary to collect that data and report it. CMS is also making technical changes regarding data submission requirements, the manner in which data is submitted, and the timeliness of the data submissions as well. So we got, again, refinements in the quality reporting program to match that change in the overall reimbursement model. So again, as I noted, your payment adjustment varies depending on whether you have successfully reported your quality data. And so you see here on the screen the typical tables that we see in every proposed rule of how that base rate is calculated. As you see, if you are if you report your quality data, your base rate is going to be about just shy of $2,000. If you do not report your data, your base rate is going to be about $40 less. So it's obviously significantly impactful across multiple 30-day episodes. CMS is also making changes to refine the home health value-based purchasing model. There are changes that will be effective for the 2025 performance year. So you, again, have that full year to develop processes to collect the data for purposes of the value-based purchasing model. Remember, we haven't hit the adjustment yet for this model because there's always this 2-year drag. So these new methodology to be used in 2025 are going to impact the 2027 adjustments. Again, you're seeing a higher use of that discharge function score now that that data is available because of that functional impairment component of the reimbursement. You're also seeing utilization of a different claims-based model regarding an individual's post-discharge experience. Some changes to the weights because we now have more measures. And then also importantly, CMS says we're going to update the model to reflect CY23 data, which again will make it more relevant on the performance thresholds. CMS also gives you that gentle reminder that the public reporting of your performance data as well as your payment adjustments will begin to be made available in December of next year. Other fun facts from the proposed HHA rule regards the refill policy for DME. And CMS has been struggling with this issue for a while. There's this concern that orders are written for long-term utilization of DME. And the question is, are we certain that the patient really needs that service for an extended period of time? We're writing an order for home oxygen, and it says for 99 months, provide home oxygen. Are we sufficiently checking to make sure that the home oxygen is becoming a plant stand and the patient in fact still needs it? So this is the balancing in terms of the refill policy. Now that we will require documentation from the DME supplier that the beneficiary confirmed the need for the refill within 30-day period prior to the end of the current supply. So you can't say, are you going to need this in 4 months? It will have to be, in fact, you need this to be refilled within the next 30 days. You cannot deliver an item more than 10 calendar days before the expected end of the current supply. So you can't have a stockpile of DME that's going to have to be coming in as the current supply is limited. And CMS, again, is seeking comments on how can we balance beneficiary burden? Because we don't want to be constantly annoying a beneficiary, like, do you still need this? Do you still need this? Do you still need this? Because some DME, of course, is a lifetime utilization going forward. But at the same time, we don't want to be paying for DME that's not necessary. So beyond these refill policy changes, are there other steps we could be taking?
And if anyone is commenting on that particular provision, I think one thing that would be important is to look at different types of DME. Because yes, oxygen, look at diagnosis and look at the type of equipment. Because there are instances that no, I don't need oxygen forever. There are other times when I might. There are times when a wheelchair is going to be a temporary thing versus a permanent fixture in order for the patient. So I really think that if you're commenting on this, it might be important to comment from the perspective of, don't automatically make a provision that applies to all DME. Do it from the perspective of what is really appropriate for the patient's condition and the type of equipment being used.
Although the hospice payment rule is on the federal fiscal year, so we've already talked about the proposed hospice rule, there are provisions in the home health rule that impact hospices. And specifically, it is the enrollment of new hospices. There has been concern that we're not appropriately validating a hospice provider prior to enrolling them in Medicare. And so CMS now proposes to move hospices to the highest level of provider enrollment application screening, which means fingerprints for all the owners of the organization. They also want to expand the home health provision that talks about majority ownership provisions to include changes in hospice ownership as well. And then they also want to clarify the definition of managing employee within the regulation, again, for enrollment purposes, includes the hospice administrator as well as the medical director. So obviously higher scrutiny there. That is reflected in the hospice special focus program, which again, CMS was required to implement this program under the Consolidated Appropriations Act of 2021. The idea is, how do we identify poorly performing hospices and how do we either subject them to a performance improvement plan or corrective action plan, or kick those out that aren't performing well. CMS has been very diligent in its implementation of this model, having convened a technical expert panel to try and identify what are the algorithms and the methodology we should employ to identify those poorly performing hospices. So again, we're not relying on just quality reporting, we're going deeper down to see what these hospices are doing. And so they are proposing now what the criteria for identifying a hospice to go under the special focus program would be. This is, again, another interesting one to watch. I mean, granted, this was mandated by Congress for hospices, but I can't think it's too far behind that there wouldn't be other providers that may potentially be subject to this type of scrutiny through CMS. Sorry, we're not advancing. There we go. Finally, last topic under HHA is a request for information regarding home health aides. Obviously, labor shortage is on CMS's mind. So they are asking the industry, how can we assure appropriate access to and provision of home health services aides for all beneficiaries? What are the barriers and obstacles that you as providers are facing with regard to recruitment and training? And what are the ways we can ensure that aides are consistently paid wages that are equivalent to other care settings and the impact they have on care? I mean, obviously, it is difficult to recruit home health aides if you can only pay what McDonald's is paying. This is certainly a more challenging job. But this is an invitation, I think, from CMS saying, tell us why we need to give you more money to compensate your home health aides. So make the case for us. So for HHAs, I think it's very important to pay attention to this request for information, provide data from your experience to CMS, because I think this could become the basis for potential new revenue for HHA organizations. So enough on HHAs, that was a lot. Kathy, let's talk about end-stage renal disease.
Okay, I'm going to make this one very short because we've got a couple of more topics we want to make sure we get to. But for the calendar year 2024 end-stage renal disease proposed rule, comments on this particular rule was issued on June 30th with comments being due August 25th. So again, if you are an ESRD provider, please make sure that you comment as well. And there are a couple of areas I think are most important to comment on. Just as a refresher for those who are not familiar, the ESRD PPS program is a bundled payment rate per treatment. Patients who are receiving dialysis services usually receive care usually about 3 times a week. So from a payment perspective, CMS is proposing an increase of 1.7% in the base rate, fairly low compared to what we're seeing in terms of increases in drugs and salary costs, but recognize a 1.7% increase in the rates. They are going to update the outlier threshold using more recent claims data, 2022. And a couple of provisions related to the low volume payment adjustment that I think are definitely worth commenting on. First would be a proposal that would allow facilities to close temporarily and then reopen in response to a disaster or an emergency and still receive that low volume payment adjustment. So recognize that this is something that was experienced during the public health emergency, where there were issues related to dialysis facilities that, because of staffing issues, things like that, there were concerns about being able to provide care. This would actually allow those services to close temporarily, reopen, and receive an adjustment and payment. This is a proposal. If you think it's good, comment on it. There is also the ability to maintain your status as a low volume provider if your counts go up suddenly because of treating a large volume of patients who were displaced because of an emergency. Again, during the public health emergency with COVID, we had ESRD facilities that were not able to stay open, but other providers took those patients in. There was a question of them keeping their LVPA payment adjustment, and so this would be actually a proposal that allows that. Last but not least,
Wait, Kathy, why only ESRD? What about low volume hospitals? I mean, why are they only applying the policy?
Great question, and might be one of those things. If I remember, the low volume hospital issue comes in under the OPPS rule or inpatient rule.
One of the two, but it's certainly something worth commenting on. Like ACMS,
yeah,
sorry,
because you don't want to lose that low volume payment adjustment in the case of an emergency where you had to step in and provide care.
Or a critical access hospital exceeding its 96-hour limit because of the same reason, right?
Exactly. They are also proposing one other issue related to a low volume payment adjustment or similar to the low volume payment adjustment, and that is whether or not there should be an add-on payment for those hospitals or those ESRD facilities that are geographically isolated. Should there be an adjustment for those providers in terms of care? For those providers, ESRD providers who thought administrative burden was bad enough, we are looking at a proposal related to additional administrative reporting. First of all, there would be a requirement to report time on the machine for care provided in an ESRD center. So you would be tracking the actual time the patient was on the machine, reporting this on your claim. And then there is also a proposal related to, similar to what was in effect July 1 for hospitals, reporting on your claims discarded amounts or discarded or unused amounts of single-use drugs, and reporting that amount on your claim as well. So again, something that you might want to be commenting on in terms of administrative burden. They are looking at an add-on payment for pediatric ESRD of 30% per treatment, and this is intended to address the complexity and the costliness of pediatric patients. So I think this is a definite positive and worthy of comment. And then they're also proposing for those new renal dialysis drugs and products that are currently receiving a 2-year post-transitional drug add-on payment adjustment to provide an additional 3-year period of additional payment for those drugs. So again, a positive in terms of the actual care delivery and payment for that care. All worthy of comment, because if you don't comment, they might not do it. And then from the Quality Incentive Program for ESRD for payment year 2026, which means reporting would be in 2024, they would be adding the facility commitment to health equity, Also, the revised COVID-19 vaccination coverage updated to comply with CDSC measure specs. They're going to convert the clinical depression screening and follow-up to a clinical measure, remove a couple of provisions, and then last but not least, for payment year 2027, they would be adding screening for your social drivers of health and your screen positive rate for social drivers, the additional measures. Recognize that when they are doing this with hospitals, they're using it as a way to propose additional payment. So reporting this information becomes important if it can drive payment as well. Martie?
You know, there is an advantage to obsessively checking the Federal Register to see if the OPPS rule has published. So yesterday, as I was doing so, in the public inspection queue was this request for information regarding medical payment products. And it was just a surprise and a treat. And you can read it now in your Federal Register published today. Comments on this, or I guess response to the request for information, are due to to September 10th. So this is a multi-agency request. It comes from CMS, the Consumer Financial Protection Bureau, as well as the Department of Treasury. And what they are looking for is input from the industry regarding the prevalence, the nature, and the impact of commercial medical payment products. What they're referring to here are those medical credit cards and installment loans that individuals utilize to pay medical expenses. And they are looking for a potential policy solution to address any negative impacts. Why the agencies are concerned today about medical payment products is because they've seen a significant growth in the use of these products over the last decade. They have seen that they have identified that these products charge a higher interest rate than general purpose credit cards, and that they are seeing anecdotal evidence of providers promoting these cards for a variety of reasons, to earn incentives for the financial institutions that provide these cards, to avoid providing financial assistance to qualifying individuals. Now, you've got this expense you can't pay, but look, we've got this medical credit card that you can utilize. So that's what they're believing. Instead of suggesting that the patient be screened under the financial assistance policy, they're instead offering this credit card to cover those expenses. We're seeing instances where they believe, again, anecdotal evidence that providers are using this to avoid assisting patients in securing coverage, determining if they qualify for Medicaid or if they're available, if there's a marketplace plan that works for them, or having to refer patients to in-network providers instead of the patient incurring out-of-network expenses. They believe that this is an opportunity. They believe, again, anecdotal evidence that they are using this to charge patients higher prices for goods and services. They're using that high charge master rate to calculate the debt under these cards, or they're using it to avoid consumer protection laws because there are certain rules that apply to medical debt that if this was converted to a different type of debt, they could avoid the utilization, the application of those rules.
Before you go on, Martie, I just want to go back and make a comment on at least one of those points that they believe, anecdotal evidence, etc., and that relates to the high interest rates. Some of these cards, it is my understanding, if you have a set, you owe $1,000 and you agree to pay it off over the course of a year, there will be no interest as long as you make your payments and you pay it off over the course of a year. If you take 15 months, interest will come in. But if the patient is following what they signed up to do, in many instances, there is no interest. So again, we're going to ask the question about whether or not you use these as from a provider perspective, not a personal perspective, but recognize that different products have different rules, and it becomes really concerning if they are just assuming that this is happening without looking specifically. If you do use one of these products or make it available through your organization, you need to get them to comment on this RFI as well.
So each of the three agencies have their own questions that they request input on. The Consumer Financial Protection Bureau, of course, is looking at this from consumer protection viewpoint. Are providers taking advantage of patients' trust in them and believing that the provider's acting in their best interests and saying this is the best way to finance your medical debt? Is it leading to higher out-of-pocket costs for patients when you utilize these products, or is it contributing to healthcare inflation? CMS is all about compliance and their questions. Is this raising concerns under the No Surprises Act? Is this consistent with hospital price transparency rules? Are there anti-kickback issues here when you have an organization that's receiving an incentive payment to offer these products to their patients, or an association's receiving an incentive payment to offer it to providers who are part of the association for them to offer it to their patients? We know that's certainly going on. And then this big question that they ask at the end, how can HHS improve patient understanding of the options for covering the cost of medical treatment? At what point in the care process should patients be provided with information about their financial obligations and payment options?
Wait
a second. And this is the attitude that I think when you read this document, you're going to hear loud and clear, which is it is upon hospitals to fix the uninsured problem. It is just, if you've got individuals that can't pay for your care, then we're putting the burden on you hospitals to figure out what to do, as opposed to looking at this as a more broad societal issue of how do we pay for healthcare in an equitable manner. Sorry, a little bit on my high horse there, Kathy, if you want to add anything.
Nope, you're good.
Okay, and then the Department of Treasury, of course, is concerned about whether there's 501R issues potentially in the use of these cards. And are they, there are restrictions that exist on extraordinary collection actions by not-for-profit hospitals. Are hospitals trying to avoid that by using these payment products? And are hospitals claiming improperly that these medical payment products provide some sort of community benefit or constitute financial assistance offered by the hospital? So their concern, of course, is are the not-for-profit hospitals acting improperly? There's a whole lot of blame game, I think, in this document. And yesterday, as Kathy and I were reading provisions of it back and forth to each other, it is something worthy of your attention, because this is how things like price transparency and the No Surprises Act get started, because you hear all the anecdotal evidence of bad actors, and the solution becomes an across the industry set of regulatory requirements, as opposed to trying to identify specifically where are the bad actors and how do we regulate the bad actors. So this is certainly something worth comment and should be treated as if it is the potential for a new set of rules being proposed on us, and we need to certainly focus the agency's attention on what the real problem is. So that gets us, Shannon, to a quick polling question so that we have number 3 done before the end of our time.
All right, question number 3. Does your organization offer medical payment products to patients? Yes, no, unsure, or my organization is not a healthcare provider. I'll give you about 25 more seconds to answer that one. And this is your 3rd and final poll question. All right, Kathy and Marty, back to you.
Fair number. Yeah.
For those who are unsure, find out.
Yeah. Okay.
And then very quickly, No Surprises Act. Just wanted to make sure that you were aware that there was an update to the FAQs that was issued on July 7th. Again, we were looking for the outpatient rule, but no comment there. But there was an update on the FAQs. And this is not as applicable to hospitals unless you actually have a health insurance product that you offer. But for services that are furnished outside of a hospital setting, think about an ambulatory surgical center. If you charge or have a facility fee, then there is going to be a requirement, or there is a requirement. CMS has said that the plans and issuers are going to be required to report facility fee options if a patient inquires about What is it going to cost me to have a surgery at XYZ ambulatory surgical center compared to ABC ambulatory surgical center? Then they are going to have to include not just the cost of the surgery itself, but any facility fees that are included in that particular service. This would also apply to dentists and others. And if you are a provider who has a facility fee, again, this is not in a hospital setting, but a provider with a facility fee, hospital, it does apply to you because you've already included that in your good faith estimate. But for other provider types who have facility fees, you need to make sure you include that in your GFE that you provide to a patient. Again, an ambulatory surgical center can't just say that the cost of the surgery is going to be X. They're going to have to tell you, and then there is a facility fee that is Y. So that has to be included in what is reported out to the patient. And Marty, what are we doing next?
We're not sure, but anyway, so join us again, July 26th. We're going to cover hospital OPPS then, because it better be out by then, darn it. We're also going to provide an overview of the Medicare physician fee schedule proposed rule. We're planning 90 minutes. It'll be at 1.5 units of CPE. Probably on August 2nd or 9th, not certain on the date yet, we'll take a little deeper dive into the fee schedule, specifically focusing on those coding issues always inherent in the rule. August 16th, we'll do the final rules. Woohoo! IPPS, inpatient psych, inpatient rehab,
skilled nursing.
Hospice, skilled nursing, right. And then on August 30, Karen Anderson and Tracy Waugh of the firm will be joining you for an EMTALA update. Also, just to note, on July 20, we'll be starting our new webinar series with Tynan Kluger and Angie Caldwell. We'll be doing an unscripted on provider compensation in the future. So I hope you can join us for those. Thanks for your attention. Sorry about the OPPS, and have a good one.
Take care.
Kathy and Marty, thank you for a fun and informative time as always. Later today, you'll receive an email with their contact information and a recording of this webinar. Also, the slides and recordings for every episode of PYA's Healthcare Regulatory Roundup series are available on the Insights page at our website, pyapc.com. While you're there, you can register for all the other PYA webinars that Marty just walked us through and learn more about the full range of services offered by PYA. Please remember to stay on the line once this disconnects to complete a short survey and post any questions you may have. And on behalf of PYA, thanks so much for joining us and have a great rest of your day.